So cancer is, as you all know, the leading cause of death worldwide, and the only way to really bring down the number is through better detection and through prevention. We've heard a lot about new technologies today. We've heard about new screening technologies. There are even vaccines for some cancers. There are all kinds of new diagnostics and treatments. How excited are you guys about the prospects for really making a dent in the problem? Why don't I start with you?
So I'm incredibly excited about the moment that we're in. I think about this as we're starting to write the last chapter on the war on cancer. I look at the liquid biopsies, the multi-cancer early detection screenings. They're incredible. The new immune therapies, incredible. We're going to get smarter. I think the big challenge that sits in front of us is really public policy. Public policy is not keeping pace with the technology and the new capacity that we have. And this is where you out there in the audience, stream, have an incredibly important role to play, because public policy is not going to get changed without you. And so you have a really incredible role to play, and hopefully we'll talk a little bit about that more.
Oh, we will get into that. But first, excited?
So I'm excited about everything oncology. So I'm a medical oncologist by training. When I went to the Centers for Disease Control, people were like, what is that about? Not treating cancer. And I think what I'm going to go old school, and what I'm excited about is the newer ways to present information to patients or to the public, how to talk in more plain language in ways that people can understand. And also to just bring it home that it is about, we heard this several times on the survivor panel at lunch, to bring it home that it's all about you and how can we assist you in taking better care or taking care of yourself and your family.
Michael, are you also an optimist?
Yeah, I am an optimist. You know, I think I agree with both of you around the public policy and obviously communications. But I also think it's how do we actually then create the change, right? And I think we've seen a lot of this even just over the last couple of years in health equity and the concentration on access for patients. So I think just the fact that we're having those conversations and we're having them a lot more and really looking at the solutions, especially those that have been grounded in science, is really exciting.
So some of these things that you have mentioned and have been explored here today are expensive. They aren't accessible to everybody. Is there a possibility that they actually increase the inequities?
So the answer is absolutely yes. I'll give you a very precise example. There is a multi-cancer early detection screening that's in the marketplace right now. If you got $900, you can get it. It will test you for 50 different cancers, find them at stage 1 and 2. They're not available to poor communities. Mm-hmm. And so what's about to happen is that the affluent will get their cancers diagnosed at stage 1 and 2 when they're highly treatable, and poor people will live with metastasized cancer.
Right.
The only thing I would just say is I don't disagree with some of that. I just think how do we look not just this year, next year, but in the years to come. So let's say the next 2-3 years, how many more of these blood tests, maybe not all cancers, but specific cancers like colorectal, et cetera, can we have, and how much more sensitive and specific can these tests become? And if, in fact, they are blood tests, the one thing I would say about access is we can bring them to those patients. So if you think about barriers to screening, especially barriers to prevention, et cetera, it is often transportation, time off work, et cetera. And yes, right now, you're absolutely right. You know, the tests that are out there right now, it's rich people's medicine. But I do think in the next couple of years, hopefully, will we be able to reduce some of those barriers.
So I just want to add something really quickly. In our division, one of our guiding principles is to begin with the end in mind. I think Jamie said that multiple times at lunchtime. How can we build in these things that will make it more equitable in the future? To your point, 5 to 10 years from now, that we aren't lagging behind. There's certain groups who can't get the care that they need. Because these drugs, you know, as I said, as an oncologist, these drugs are amazing if you are going to respond and if you can afford it. And so how can we get it to everyone who needs that?
Lisa, I want to talk for a bit more about screening, which is available for many cancers, but a lot of people do not get screened. What is the CDC doing to try and reach those people?
So we're developing a ton of new resources. So one of the things as well is, what is the language that we're speaking to the public? What we did in a study where we looked at breast cancer screening, what we learned was everybody, the message resonates with everyone the same. It's just, what does it look like? How creative are we going to be using the language of the community? One study in particular that we're doing, that we based on a Kaiser study, is something called boot camp translation. So you take the messages to the public and they help you develop the messages, and then you re-deliver it back to the community. I think that's where we've lost it over time. We're talking to ourselves, is what I believe. So at CDC, we're trying to get back into the community, talking to people who actually need the services that we recommend for them.
Gary, you're working on something called the Stage Shifting Initiative. Explain what that is.
So, because of public policy, we have communities around the country that have been exposed to carcinogens. Flint, Michigan, Cancer Alley in New Orleans, Houston, Texas, Missouri, Jackson, Mississippi. Those same communities are also not getting advanced medical care. We call them medically underserved cancer care communities. So what my organization wants to do with these communities is to stage shift them, because when you go look at the data, what you see is they get diagnosed for cancer late, their survival rates are poor, they're not in the clinical trials. You go into those communities and they have deep concerns about cancer. So we want to use those MSIDs, those multi-cancer early detections, as a surveillance tool. Because what we want to try to do by surveilling them, meaning thousands of people at one time that we want to test, hopefully we can find them at stage 1 and 2. That's part of the work that we're doing under the Cancer Moonshot that you heard earlier this morning about. And so that's our contribution to the Cancer Moonshot, is to stage shift these communities from late stage diagnosis of cancer to early stage diagnosis.
But only those select communities, for now.
For now, because it's a clinical study, because these MSIDs are not available, they're not reimbursed by Medicare, they're not reimbursed by Medicaid, and so we need good science to go back to Medicare and Medicaid and say, yes, you could use these tools, here's what it costs, because we're also going to collect the cost data, here's what's going to cost to actually surveil these populations.
Has this effort started already?
Oh yeah, we're in full throw for that. We created a report to the White House to explain how we want to do this technology, and we're asking for all kinds of volunteers, because sometimes in this country we don't get together to do big things. This is a big thing, because this will help us understand how to bring the Cancer Moonshot to community. Because at the end of the day, the moonshot has got to happen in every American neighborhood, and that's what we're working on.
Michael, what's Blue HQ?
Blue HQ is a first of its kind, personalized treatment portal, I guess is what we would say. So really, if a patient's diagnosed and they go to any advocacy organization, including the CDC or the Colorectal Cancer Alliance, et cetera, they look for services, to be empowered, et cetera, biomarker information, screening information. But it's often hard to find all of that information, right? There's a million things you need to know. Well, the whole point of Blue HQ, one, is a one-stop shop for everything, from screening to clinical trials to biomarker to what we call psychosocial support to financial support to community, right? And then the second is once we have their information, we utilize AI to make sure that we are giving that patient or that caregiver or that family only information that is pertinent to them.
You trust the AI to do that. We had a long discussion about this earlier.
100%. Why? It's because it's not super complex, right? If someone has a KRAS mutation or a BRAF mutation, or they are talking in a community forum about X, Y, and Z, we're not talking super complex, data sets. It's pretty simple AI.
So I just wanted to add on to what the two gentlemen said about, policy, finding resources. The community really is, as the public health person here, the community really is where the solutions are. There's something called positive deviance. There's like places where you would expect people not to do as well, who do better than the average, and they also do better, and whites and blacks do the same. The example I know the best is breast cancer. So there are lessons to be learned in communities where you can go in and say, why is that community different? Why is everybody doing well? Why are black women doing better than others? And so that to me, again, based on what you just said, the resources have to be there obviously to get the person treated, but there's a lot of things that go on in the community that are really invisible to us, and it would behoove us to go find out why people are doing well in some places and not others.
So two things I hear about when we're talking about screening: fear.
Mm-hmm, absolutely.
People don't really want to know sometimes.
Yes.
And two, confusion, because guidelines change.
Yes.
How profound are those problems?
I would add a third one to it, which is financial toxicity. Because if you get diagnosed, then the finances kick in. And in the communities that we work in, we hear from people that they don't want to know because of the financial implications of it. And that is part of the reason why we have a collective responsibility to make sure that when someone has cancer, that they get the care that they need. We already do that for end-stage renal disease. I mean, if you come down with end-stage renal disease, the resources there to take care of you. We do that with ALS. We can do that with cancer. We can make sure that everyone who has cancer has access to best modern therapy and not having to deal with the financial toxicity.
Lisa, you mentioned communications.
Right.
We have not cracked that one. People have not heard the messages about smoking, about eating better, about getting exercise, all of those things that can help prevent cancer. Right. Why? And do you see any way to crack that code?
So a lot of it, again, is what is priority for people in their lives, right? Quite a bit of the socioeconomic status, social determinants of health factors out there. The cancer screening may not be a priority. What you said as well is, what is the confusion around this group has this recommendation, this group has that recommendation, what am I supposed to do?
Yeah, straighten out the red wine recommendation.
Well, I can't do that, but I will say that, so it really is, and also speaking in language that people can understand. Like, why would I go get a colonoscopy, to your point, if you're going to find cancer, then what am I going to do about it? Well, the truth is, almost every single screening test we do does not find cancer. So how do we flip it into a wellness test instead of a disease test? It really is about how do we talk about what it is we need people to do. But the vast majority of screening tests for every cancer that is recommended for does not find cancer. But we're looking for it because we don't want you to have cancer. We don't want it to be late stage. So...
Yeah, I think one of the other things about communication is, so we did this campaign last year called Lead from Behind with Ryan Reynolds and Rob McElhenney. And I think what we often don't do, yes, we look at, things that are proven, but what we don't do is look at the cultural relevancy and the timing of that. So we launched this campaign last September. There was a 36% increase in the number of colonoscopies that were booked in the month after, according to ZocDoc and Axios. Right. So making sure, again, not only that we have big celebrities doing it, because yes, that sometimes works and sometimes doesn't work, but that we have the right cultural moment, right, the right messaging. And then the other thing I would just say, if you look at colorectal cancer, right, we changed the screen age to 45. Right. Most people do not know that, right? And right now it's about a 20 to 25% screening rate from 45 to 49. So how do we then, as you guys are saying, get into the community and making sure that there are real people, that they look like you, they act like you, they're in places that you go, get the information out?
Are you finding it harder to get the cancer message across because of the anti-science sentiment that has swept some portions of the nation?
The communities that we've been working in, there is a deep, deep fear of cancer because their families have experienced cancer, their neighbors have experienced cancer, the cancers are more aggressive, people come down with multiple kinds of cancers, because we're talking about communities that have been exposed to carcinogens, right? And so what they fear is the absence of help. That's what they're complaining about. They're complaining about no one has come into those communities and helped. So I have to do this because I come from Washington. There is a bill, H.R. 2407. H.R. 2407. It is to begin the conversation about spending for these multi-cancer early detection. I encourage you, all of the cancer groups have basically signed on to it. 60% of Congress has signed on to it. But we're in this crazy political moment where they need a little encouragement. So I ask you to send a note to your legislator to encourage that, because those communities need that technology. We have to get them screened as quickly as possible. So here's a way that you could help.
Science, anti-science, are you seeing it, feeling it, hearing it?
Well, in some ways, we've sort of dealt with this at CDC for quite some time. Every time a new recommendation comes out, we get the wave back, like, what about this? What about that? Why didn't you include this age group? And it really is about being as clear as we possibly can be about why should you be screened? What is the evidence? But also to speak to the follow-up, that when we're confused, and we did a study on this, when breast cancer screening prevalence dropped, we did a study, and one of the main outcomes was people said, well, if the experts don't agree, what am I supposed to do, right? And so that might be one of the solutions as well. I think we've worked on this some, but, for all of us to get together and come up with a recommendation that makes sense for everyone.
What I say is, if you don't do it for yourself, do it for your family. Mm-hmm. My mom was 56 years old when she died of colorectal cancer. She never had her colon cancer screening, and there's no arguing with that, period, right? So I think it's really important that we use emotion in our communications. We use things that every single American has. They have moms, they have dads, they have sisters, they have brothers, they have kids, etc., and that can be very, very compelling.
So I want to flip a little bit. I'm a physician, so I'm talking about myself. We don't recommend screening to everyone. We heard that earlier. So so the next prong is sort of to go with, talking with providers and helping them with tools where they ask. One of the things that we've done in our colon cancer control program at CDC is we've instituted systems changes, how the health system actually works, so that you're not depending upon the frail mind of Lisa, Dr. Richardson, to remember that you need something. The records will pop up a reminder to your provider, and that is still the most powerful predictor of people getting screened, is that my healthcare provider recommended that I do it, and so here I am. So again, we got to work on both sides of the equation.
Oh, we're going to take your questions in just a minute, but before we do, policy. You said there had to be policy changes. What policy changes?
So, depending on where you get your health insurance tells you a lot about what care you're going to get, right? So personally, if I had to deal with cancer, I wouldn't want to be in a Medicaid program. I'm sorry, but I don't think you want to do that, right?
And that's the only option for a lot of people.
105 million Americans, 1/3 of the U.S. population, is Medicaid eligible. During the pandemic, 90 million Americans were getting their health insurance through the Medicaid program, right? And so collectively, we have a responsibility to each other to make sure that when you're in a public health insurance program, you have access to best modern therapy. Yeah. That's stuff that we do together. You know what I always say? You always know what health care you want, but what we're really arguing about is what health care should I give my neighbor? That's the problem. It's my neighbor's health care that I don't want to pay for. What I'm saying to you is they're the same thing. Mm-hmm. They're exactly the same thing. And that's the public policy changes that we need to think about.
Policy changes from either of you? Suggestions?
What he just said is actually profound. One of the things that we do in our screening program for uninsured women, based on some movements by Congress when way back in the day, is that if you're screened through our program for women who don't have health insurance and you're, poor, the treatment is mandated through Medicaid, given the problems that you discussed. But I still think, again, there's an opportunity for training and learning in the system as to what people should be getting to make sure that they get it. As you said, a community group, effort, not just one place.
Yeah, the only thing that I would say about from a policy perspective is, again, what Gary was saying at the beginning, which is that our government hasn't necessarily caught up to our technology, et cetera. And we need policy changes and the right people that make these decisions. We were talking about this earlier, the United States Preventive Services Task Force. They're amazing people, awesome group, way underfunded, and they're helping make recommendations for almost every single person in this country, whether it's cancer or other diseases. So why is their budget only $12 million? Right? And so that's a huge, huge thing that we probably could change very easily.
We do have a question here. Go right ahead.
Hi, kind of a comment. Appreciate all of the intelligence in the room and the will to keep people healthy. As a physician for practicing for 35 plus years, I'm in the business of upstream thinking and trying to promote health, which doesn't seem to be aligned with our general healthcare system in general. I consider myself a public health advocate. The science is clear. 80% of chronic diseases can be prevented with lifestyle changes. Simple things, not expensive. Whole food, plant-based diet, exercise, lack of alcohol, sleep.
I do exercise.
Sleep, stress. Once we start aligning our will with the funding and having an upstream approach, things will get much better. We have the science, we have the evidence, we just have to start thinking like that.
Let me ask you,
yes,
if your patients heed that advice.
Absolutely. My secret sauce is, though, I spend more time with patients because I have to actually have the conversations. My dad asked me the same thing. How many people become vegetarians? How many people, with an authority, with science, somebody having an actual conversation with a patient? Respectfully, this is not going to be done through AI or the latest biotech. This is messy, on the ground, regular conversations that are evidence-based, and that is the only way, and I'm old enough to say so, that we can really make changes in our healthcare system and actually take care of people, which is what I think we all want to do.
Michael?
Yeah, the only thing that I would say, yes, I completely agree, but I can't tell you how many marathon running, cardboard eating people I have met that have been diagnosed with cancer, meaning that 60% of them are sporadic, right? So do I believe, especially for the young onset and the increase in young onset colorectal cancer, that diet, lifestyle, exercise, alcohol, et cetera, plays a role? But I also think there has to be a role for prevention, right? We've got to get people, exactly what you're saying, get screened, right?
You can do both.
I don't disagree.
It comes back to that communications issue. This isn't rocket science, and we've been hearing it for decades.
But here's the practical reality now. when you go into underserved communities, what you see is the clinician has a patient panel of 5,000 or 6,000 people, right? No way they're having that conversation. They got 10 minutes, right? 10 minutes. And the system is designed to do that, right? And that's what I'm talking about. We set up the public policy to fail because we don't have the resources and capabilities in those communities to have the conversation that you're talking about.
So we're almost out of time. I want to ask all of you for your number one recommendation on what could be done to change the cancer picture that we see now. And you can make it about policy, you can make it about patients, you can make it about physicians, your choice. Lisa, you want to go first?
Sure, I'm gonna start because I wanted to add on to what you just said. It is messy, and I believe the thing that will work the best is the personal touch. We can go all that technology till you know what freezes over, right? But people still want to talk. You want to talk to your patients, but that's what I think it is. It's old school. We just have to remember, and also it's one person at a time. I'm a stats person, but when I was, a fellow, I got one guy to quit smoking. I was over the moon flipping around in the hallways, right? That's one less person who might get lung cancer. It wasn't 50% of all veterans I saw in my clinic. So it's just still, it's the personal touch, I believe.
Number one?
Yeah, for me with colorectal cancer, it's what we call risk stratification. So if you have a family history, you need to get a colonoscopy. If you don't necessarily have a family history, you don't necessarily need to get a colonoscopy. And so how do we do a better job of determining risk, knowing family history, et cetera, so the right people get screened with the right test at the right time?
Gary, last word?
I believe deeply in the cancer moonshot. Probably for me, the most important component of the cancer moonshot is the collaboration. That all of us working together can actually bring cancer under control. I think that is probably the deepest message I can give you. It is a matter of public will. What we think about is when Kennedy was asked, why did he want to go to the moon? His answer was an unwillingness to, I've forgotten the last word of it, unwillingness to postpone, right? That's what we have to have with cancer. We have to have an unwillingness to postpone, the sense of the immediate, that we could do this right now in every American community. That's what I take away from the Cancer Moonshot.
And that's the perfect note to end on. Thank you all. Appreciate it. And thank you, too.
Please welcome back to the stage the Atlantic's Candace Montgomery.